Good evening and welcome to the 7th series of our weekly upper GI surgery virtual grand round. Every week since March, our program has brought together upper GI surgeons from all around the country, from multiple upper GI centers in Malaysia, to share their experience and expertise on management of various common upper GI diseases. Special shout out to Mr. Shukri for bringing us together to make this collaboration possible. I am Dr. Ooi from Hospital Queen Elizabeth, and together with my co-chairperson today, Mr. Shukri from National Cancer Institute, will be hosting you. Dr. Hashimah, unfortunately, is unable to join us today as she has an emergency surgery to perform at the moment. It gives me great pleasure to introduce our speaker today, Dr. Mohanarajah from National Cancer Institute. Already an experienced surgeon, Dr. Mohanarajah is now a fellow in upper GI surgery subspecialty training program, with none other than the Grandmaster himself, Mr. Shukri Jahid. Dr. Mohan will be delivering the topic today, a long journey of a short bowel. Now, before we start, some housekeeping notes. Your audio will be muted during this webinar, but you can still make this a lively grand round by interacting with us. You can post questions to Dr. Mohan, Mr. Shukri, or myself through the Q&A window. And also do not forget to participate in the polls during the talk. This webinar is being recorded for internal use. E-certificate will be sent to you at the end of the webinar series. You may use this certificate as proof of attendance to claim your points with NSR or MMA. We will send a survey link to your email after the webinar. Your feedback will help us to improve further for our webinars in the future. For any inquiry related to sponsor's product, you may leave the question in the survey. The sponsor will contact you directly thereafter. So, I hope you could brew yourself a cup of coffee, sit back, relax on this beautiful Friday evening and enjoy this presentation. Take it away, Dr. Mohan.
Hello, thank you, Mr. Ooi, for the kind intro. My topic for tonight is about short bowel. And those of us who have managed short bowel in the past, you know it takes dedication and perseverance in managing this patient. It's certainly a long journey for both the surgeon as well as for the patient. I'd like to start by saying I have no disclaimers. And my presentation outline today will be an introductory question, a concept of intestinal failure and short bowel syndrome, overall management of short bowel, and a case discussion. Let us come to our first question for tonight. Does normal urea and creatinine level rules out dehydration among patients with high output stoma losses? We shall answer this question at the end of the evening today. All right, we'll come to our second question for tonight. Should we advise short bowel patient that has high output stoma to drink more water? Yes, no, unsure? All right, fine. Let's come to our third question for tonight. Should we prescribe elemental diet to all short bowel patients? We'll answer this question at the end of our presentation today. Okay, coming to the topic itself. When the body gets an insult, the first organ to fail is the gut. Blood will get shunned from the gut to more vital structures, such as the heart, the lung, and the brain. We often see this after patient post-myocardial infarction and in patient severe sepsis. We will also get referrals from the ICU saying that the patient's abdomen is distended and unable to tolerate feed. So understanding this concept of intestinal failure is crucial in our day-to-day management and patient care. In the 1980s, Fleming and Remington has actually defined it as reduction in gut mass below the minimal necessary amount for digestion and absorption of fluid. At that time, they actually focused on the mass of the bowel itself. But after 40 years, there were a bit of modification, and currently they're actually focusing on the function of the gut rather than the mass of the gut itself. And Aspen has actually defined it as reduction of gut function below the minimum for the absorption of macronutrient or water electrolyte, such that intravenous supplementation is required to maintain health and growth. Let us come to the classification, which is the pathophysiological classification. This classification will actually tell us the cause of the intestinal failure. The first is short bowel. As you can see, short bowel is a subset of intestinal failure. And patients that get short bowel is usually after surgery, such as trauma and resection of tumor and multiple enterotomies. Second cause is intracutaneous fistula. This can be spontaneous, usually seen in patients with Crohn's colitis, or it can be due to multiple surgeries and bowel resection, as you can see in this picture. If this intracutaneous fistula is placed proximal in the gut system, whatever the patient consumes will come out through this fistula, and the patient will not be able to absorb any form of nutrition, and this will lead to intestinal failure. Next, with mucosal disease. As you can see in the histopath picture, on the right side is a histopath picture of a normal bowel. You can see the thickness of the bowel as well as the length of the villi. On the left side, sorry. On the right side is a radiated bowel. You can see the muscular layer is actually replaced by collagen, and the length of the villi is actually reduced. This indirectly will reduce the surface of the small bowel, and it reduces the absorption capacity of the bowel itself. This is a picture of a patient on chemotherapy. The effect of chemotherapy will be to the basal membrane of the gut, and it inhibits proliferation and growth of the villi. If you can see in the image, there's multiple ulcers and there's flattening of the villi itself. And this hampers absorption of any form of nutrition. Next will be intestinal dysmotility. This is either the bowel is too slow or it moves too fast, rapid, where the transit of feed is unable to catch up with the transit of the movement of the bowel. It's usually seen in patients with severe sepsis and in patients with inflammatory bowel disease. Finally, is mechanical obstruction. This can be intraluminal or extraluminal, and it could be malignant or a benign cause, causing obstruction and increase in stomach output. The next classification is a functional classification of intestinal failure. It's actually divided into three types: type 1, type 2, and type 3. Type 1 is an acute failure, usually seen after an insult, such as head injury. This patient often will be on ileus, but usually will recover. It takes a short term, and the recovery will be good. Type 2 is usually seen, like example for a patient with anastomotic leak. This patient will have systemic imbalance, and this patient may most probably require IV nutrition support. If the initial insult is removed, this failure can be reversible. Type 3 is a more chronic type of failure where there is no systemic imbalance. The patient's gut just unable to adapt and absorb nutrition. If this process is prolonged, the failure may not be reversible, and a long-term treatment of IV nutrition need to be planned for this type of patient. Okay, let us come to the core topic for today, which is the short bowel itself. This is the basic anatomy that we usually will get with patients with short bowel. The first image is a patient with a jejunal stomy, and this patient does not have a colon nor a ileocecal junction. Patient number 2 is a jejunum colic anastomosis. This patient has a colon in circuit but does not have a ileocecal junction. And patient number 3 will be ileojejunal anastomosis. This patient does the best because they have the large colon as well as the ileocecal junction to control transit of fluid as well as increase ability of time for absorption of nutrition. Okay, there is few changes that we have to recognize in patient with short bowel compared to patient that has a normal bowel. Most of the time, the bowel will be less than 200 centimeters, and most often in the acute phase, patient may need nutrition and fluid support. The changes that we will see first is motility. The gut will produce gut hormones such as peptide YY and glucagon-like peptides. This usually is produced in the ileum and the large bowel. Patient that has short bowel may not have this function. And this hormone is important for ileal and colonic brake mechanism. And this mechanism has a role in gastric emptying and a small bowel transit. In the absence of this mechanism, the gastric emptying and the small bowel transit will be hastened and there is no braking mechanism. So the patient will have high output stomach. Next changes will be the secretion. As we know, the upper part of the GI tract will produce almost 4 liters of fluid, 0.5 liters of saliva, 2 liters of gastric juice, 1.5 liters of pancreatic biliary secretion. And all of this will be absorbed in the terminal jejunum and the ileum. Patient that does not have this will end up producing high amount of fluid that is rich in nutrition and vitamins. A patient that has a jejunal colon anastomosis, the colon can help to absorb this much of fluid, and this patient will do better compared to a patient with a jejunal stomy. And if a patient with a jejunal stomy, if you allow fluid that is less than 90 millimoles, it will add up to the amount of fluid that's been normally secreted, because there's a net influx of sodium from the plasma into a bowel lumen. And this will tremendously increase the stomal output. Next changes will be the absorptive function. These patients will have protein energy malnutrition because the gut is just too short for any form of digestion or absorption of nutrition. But if the patient has an intact colon, the colon will be able to ferment carbs and absorb some amount of nutrition. The downfall of having a colon in circuit is where the fatty acid that actually enters the colon will induce absorption of water and sodium and will cause the patient to have diarrhea. And this diarrhea is toxic to the bacteria and reduce carbohydrate fermentation. Fatty acids in the colon itself also bind with calcium and magnesium and cause increased loss in the stool. Indirectly, it will cause increased absorption of oxalate, and this patient will suffer from renal stone, oxalate-related renal stones. These patients also will have difficulty in absorbing vitamin B12 as well as bile salts. Bile salts that enters into the colon will also produce colonic secretion. And fatty acid that is not been absorbed due to absence of bile salts will have a chelating effect towards magnesium and it will cause hypomagnesemia. So basically, this is the basic 3 different changes we can see in patient with short bowel compared to patient with normal bowel function. Let us come down to the management of this patient of short bowel. The aims of managing short bowel will be reduce in gut secretion, slow down transit time, maintain integrity of bowel, and prevent nutrition deficiencies. The short gut will go through these three phases, and these three phases need to be understood so that we can manage the patient appropriately. It will be an acute phase, an adaptative phase, as well as a recovery phase. In an acute phase, it's immediately after the bowel is resected, and it can be prolonged after weeks. And this phase, patient will have high output loss. There will be poor absorption of nutrition, and there will be loss of vitamin and trace elements through the stomach. This patient also will have hypergastrinemia as well as hyperbilirubinemia. This is due to stasis of bile. Patient that has duodenostomy and ileostomy in the acute phase, you can expect a high output stomach. And this high output, we can control with anti-secretory drugs, such as PPIs, and anti-motility drugs, such as loperamide. Drugs such as tegoglutine, it is a gut hormone. It helps in promoting villi, as well as able to make the whatever colon that is remain to be thicker and increase the mucosal surface for absorption. For patient who has duodenostomy, we will accept the output to be less than 1,000 mils to be stable, and a patient that has an ileostomy, we will accept about 500 mils to be stable. Coming down to the adaptative phase, it can begin as early as 48 hours and can last as long as 2 years. And in this phase, enteral nutrition is essential. So be careful in starting the nutrition early at this point. But you have to understand and keep in mind that parenteral nutrition is still the main source of energy provider at this phase. In this phase, you can allow patient trickle feed of enteral formula. This is not to provide energy, but it will stimulate the gut, whatever remaining small bowel, to have higher blood supply. So it increases villi as well as crypts, and it will promote adaptation of the gut. It can be monitored by the stomal output, or patient that has an anastomosis, just like jejunal colic anastomosis or ileoclonic anastomosis, you can monitor with the stool output. Once the patient is tolerating this trickle feed, you can progress it, making it about 50% of total energy provider. When this happens, you can reduce down the parenteral nutrition. Once the energy provider via the enteral feed reaches about 80% of the total energy requirement, the parenteral feed can be removed. This process will be hastened if the patient has an ileocecal valve or colon in transit. Throughout this phase, we also give anti-secretory drugs as well as anti-motility drugs. We will accept a patient that has an anastomosis to produce about 3 soft stool per day. We will accept that as a norm. In this phase, enteral feed has multiple effects towards the retained small bowel. It helps in crypt cell proliferation, leading to an increase in crypt depth and also lengthening the intestinal villi. It also promotes nutrition receptors formation, and it helps in production of trophic intestinal hormones and secretion. It also helps in production of digestive enzymes and also facilitate bile flow and prevent cholestasis. In the recovery phase, this phase is where the patient will be able to tolerate enteral feed and may not be on parenteral feed at all. In this phase, you can do a definitive surgery such as reversal of a duodenostomy or ileostomy, but make sure the patient is stable metabolic and fully recovered from the initial acute illness, and there is no other risk towards further bowel injury. Some patients, even in this phase, may still require a parenteral nutrition. And for this patient, we need to plan a long-term management of giving IV nutrition as a long-term, such as home TPN. Okay, let us come down to our common mistakes. These mistakes is usually, all of us have done these mistakes in the past. So we shall learn how to correct it now. Question number 1. Does normal urea and creatinine rule out dehydration among patients with high output stoma losses? Can we have the polling answers? Okay, most of you got it right. The answer is no. This patient, most of the time, is sarcopenic. Their normal urea creatinine level may be below norm. If there's any increase of urea creatinine, even though it's in a normal range, this may be a sign of dehydration. So we need to take account of signs, symptoms, and laboratory investigation to come to a diagnosis of dehydration, and this needs to be treated promptly. Question number 2. Shall we advise short bowel patient with high output stoma to drink more? Excellent. The answer is no. As you know, if you allow 10 mL of fluid orally, this patient will produce almost 100 mL through the stoma. So usually we will restrict the amount of hypotonic fluid and we will ask the patient to take glucose saline, which has an osmolarity between more than 90 millimoles per liter. It may be difficult because it is not palatable. So usually we will ask the patient to add salt in their drinks and to their meals to the limits of palatability. Question number 3. Should we prescribe elemental diet to all short bowel patients? Okay, there's some yes, some no, and about 6% not sure. Okay, elemental diet contains little sodium. Thus, it increases somal water and sodium losses. And some elemental diet actually have low calorie content compared with polymeric diet. So you need a larger volume of this enteral formula to meet the demand of the energy. And this indirectly will increase large amount of losses through the stomach. So we prefer low fat content carbohydrate, which is high in complex polysaccharides and is high in protein as well as salt added to it. Okay, let us come to a final section of our presentation today, which is a case sharing. Okay, this patient is a 37-year-old gentleman. He was actually diagnosed to have a B-cell lymphoma and he was on treatment. He presented to the emergency department with complaints of severe abdominal pain and he was referred to the surgical team at that time. He was diagnosed to have an acute abdomen and was wheeled into the emergency theater. Emergency laparotomy was done and noted there was multiple perforation of the small bowel. The small bowel was resected and a double-barrel enterostomy was created. They left about 70 cm jejunum to the proximal limb has only 70 cm to the DJ junction, and the distal limb, they did not measure the length of it. After which, in the ward, he was allowed orally. He was producing high output stoma, and he was actually advised to drink more to replace the high output stoma. He was also put on the normal saline IV drip. Slowly but surely, his stoma output became great, and he was almost losing about 4 liters through the stoma. At this point, he was not started on any form of enteral feed, and he was referred to us. On arrival, we have noted that patients have these 5 issues, which was dehydration, electrolyte deficiency, malnutrition. We suspect the patient will be in refeeding, and he has a liver derangement. So once we have noted the issues that the patient has, we actually had a multidisciplinary approach to the patient. We call upon our friendly pharmacists, the radiologists, the dietitian, as well as the nurses to get involved in managing this patient. We initially started the patient on a low, we stopped all oral feed We started the patient on IV parenteral nutrition. We calculated about 20 kilocal per kg for the patient. We started about 50% of the total energy requirement. At the same time, we were correcting all of his electrolytes, his magnesium, phosphate, and calcium, and we were also replacing some vitamins, trace elements, as well as thiamine for the patient. We were keeping a very close eye on the amount of fluid that we are giving for the patient. Slowly, from 50%, we have increased the feed to about 100%. And this process took us almost from 2 weeks to 3 weeks to achieve this norm. Once patient was stable, well hydrated, and all of his electrolyte was corrected, at this point, we decided to delineate the patient gut anatomy. So we proceeded with a distal lupogram, and we noted that the distal limb has a significant length. So we decided to put a feeding tube in the distal limb. Started the patient on a slow infusion pump and gradually increased the amount of feed. Initially, patient had bouts of diarrhea, but slowly patient was able to tolerate the feed and was producing about 2 semi-solid stool per day. After which, we actually referred back the patient to the primary hospital, and he has managed to complete his treatment for B-cell lymphoma and was able to gain about 4 kilos during this period. Currently, he's waiting for his final surgery, which is reversal of his enterostomy. So take-home message is intestinal failure are classified as type 1, type 2, and type 3. Loss of intestinal function may occur from 5 different pathophysiological conditions. Short bowel syndrome is a subset of intestinal failure, and the critical point of managing a short bowel syndrome is during an acute phase and the adaptive phase. With that, I thank you for your time.
Thank you, Dr. Mohan, for the exciting presentation. Before we continue with the next section, we have some words from Medtronic, which is our sponsor today. Please enjoy this video about Valley Lab. All right, welcome back to our virtual Grand Round. I'm proud to announce that since our program inception, we have been receiving overwhelming response. Over 640 registered participants with an average of 200 viewers almost every week. Usually we receive many inquiries, but for this session today, Dr. Mohan has done a great job that we have not received much question today from our audience. But anyway, there are still some questions. So without any more delay, we will start with our first question. And this question goes to Dr. Mohan. Rather than adding salt to drinks, which would be horrid, why not ask them to add salt to something like clear broth or soup? This is one of the questions by our audience. Would you like to answer that, Dr. Mohan?
Okay, we can actually advise that, but we will not know the amount of salt that is added. We need to achieve about 90 millimoles of salt. So usually the basic advice is to add salt to any form of fluid that you take to reduce the hyperosmolar state. But the best is you actually cannot measure the amount of salt that you added. So the best is to actually not allow the patient anything orally if the patient actually has a high output stomach.
Yeah, I agree with you, Dr. Mohan. I think for complicated short bowel cases, we should take over, we should know all the electrolytes and the fluids that we give to the patient. If we just add salt we just help patient to add salt to their food, we might not be able to control that, and then patient might not be able to know how much to put in, and that will complicate matter further. Yeah. Okay. We have another question by our viewer. Yeah. So it goes, when is the lengthening surgery indicated for short bowel syndrome, and which type of surgery is recommended? Yeah.
Okay. Usually any form of surgery, the patient needs to be in the recovery phase. It shouldn't be done in the acute phase or adaptive phase. Once the adaptive phase is at its maximum, when the gut is at maximum and the patient can take normal feed, the patient may not need surgery. Usually we will usually do surgery for patient who is still on IV TPN that has complication from it. And there are multiple surgeries for it, such as step procedure or lid. All this depends if the bowel is dilated. For a step procedure, the bowel needs to be dilated so that you can do a transverse incision on the bowel. If the bowel is not dilated, you may not be able to have adequate transverse incision on it. So usually other surgery will be segmental intestinal anastomosis, where a small segment of the bowel is resected and you actually reverse the peristalsis and anastomosis. They believe that when the bowel, any fluid or enteral feed goes through this segment, due to the reverse peristalsis, it will slow down the transit and you will able to increase in absorption of nutrition. But all this depends on the patient, the length of the bowel that is present, and the initial insult is whether it is as patient has already come out of the initial insult.
Okay. Yeah, we have another question. Well, now the questions are start pouring in. I think we need to move a little bit faster. We have a question here about somatostatins. Would you recommend octreotide or somatostatins in high output fistula?
Okay. Somatostatin, they say you can actually give somatostatin in the initial period for a short time. You have to look at the cost of it. It's a bit expensive, somatostatin. And somatostatin has an effect of biliary stasis. So this patient in the long term can actually go for, can go into biliary stones. So usually we will not give unless we really unable to control the amount of effluent that's coming out from the stoma itself.
Yeah, that is quite correct, if I may add. And usually the hypersecretion from the stomach, the pancreatic secretion, as well as the biliary secretion, is during the first few hours or even up to a week of the acute phase. And this is just made worse by the, more and more gut hormone that's lost via the high output stoma. But that is the reason why the prescriptions of PPIs and somatostatin is indicated. If you were to read the articles and journals, it is indicated and it is recommended during the acute phase. Beyond the acute phase, okay, prescription of somatostatin does not really reduce the amount of your stoma loss, especially if you allow the patient a hypotonic solutions or even an entero formula that is hypocaloric or isotonic. All right. So having said that, prescribing somatostatins in such an expensive medical, it is just not cost effective, and you won't see that much of effect that you would like to see or expect. So on that note, Dr. Mohan, there are a few questions here which I would like to read it out to you regards to oral rehydration. Okay, since you are mentioning about allowing the patient a hypertonic solution per oral to reduce or to to relieve the dehydration, at the same time reduce the high output stoma loss. How about the oral rehydration? Would you recommend that for your patient with high output stoma loss?
ORS, is it?
Yes.
Usually, the amount of salt that is in oral rehydration is not equivalent to about is not equivalent to 90 millimoles. So usually I would not advise to take ORS as a replacement for the stomach output.
You see, if you know what is the osmolarity of your ORS, perhaps you can prescribe to your patient. But the regularly available ORS in our hospitals are not up to the standards of a minimum of 90 millimole per liter in its osmolarity. All right, with regards to the TPN or the nutrition, there's a question here about refeeding. When should you decrease your calorie requirement via TPN if you to give the patient TPN? And in this matter, I suppose those patients with high jejunostomy, short bowel, is there any time frame or goal period that you would like to achieve the 100% of the calorie requirement?
Okay, this is all depends on the patient. There's no specific timeline for me to say. It all depends on the clinical judgment of the clinician as well as the condition of the patient itself. Usually, we will start the patient on low calorie. It could be 15 kilocal per kg, about 50%. And we actually will monitor the patient's electrolyte throughout the process of giving the nutrition. If the patient's electrolyte is still in derangement, we will not increase the nutrition at that time. Once the electrolyte becomes more stable, then we can slowly increase the amount of calorie that we give to the patient. And keeping a close eye whenever we increase the calorie on the electrolyte as well. Vitamin, multivitamins as well as thiamine need to be added during this period as well.
Yeah, it is actually depends on the condition of patients. Okay, and for you to actually balance the inflammation, the response to your resuscitative fluid management, and then followed by your TPN, and then the resolution of the liver edema from the primary insults is always a tricky part. And most of the time, I'm sure Dr. Mohan would like to agree on this, that people would figure out, is it because of the TPN rather than the initial insult that the liver enzyme actually deranged, and it makes people a little bit more cautious to actually put the patient on TPN. And with regards to that, even to escalate the calorie and the nutrient requirement via the TPN. So there's another question here with regards to TPN. If I would like, hold on. Okay. With a patient who has a complete enterocutaneous fistula with a very short bowel, allowing enteral feed will lead to high stomach output, as you correctly mentioned just now. But the patient can't tolerate TPN because he is having TPN-induced hepatitis. Okay. Is there any other options to optimize this nutrition, Mohan?
Okay. Before we put a bullseye on the bag itself, we must come back to the patient and see whether the initial insult has been treated or whether there's any form of sepsis still lingering. We need to take some bloods and see whether cultures and see whether the patient has septicemia. That could be one of the reasons where the liver function is deranged. At the same time, if the patient is in the ICU, please look at the drug chart. They might have some medication that's added that may have an effect on the liver itself, that causing the liver to be deranged rather than a TPN bag itself. You also have to look at the amount of fluid as well as the left heart function to see whether there's any liver congestion going on that can cause the liver to be deranged, right? After that, you can come to the TPN itself. All TPN need to be infused through an infusion pump rather than just hanging it by itself. If it's not on the infusion pump, the infusion rate may be faster, and that may be the reason for the liver to be deranged rather than the TPN bag itself. If all of this is corrected and normal, then we can actually look at the TPN bag itself. Let's look at the composition of the bag. If the patient is receiving about carbs to fat ratio of 70 to 30, you can actually reduce it to about 60-40, making fat as the higher calorie giver compared to carbs. After which, if the patient is also having a 24 hours bag, we can actually reduce it to a 16-hour bag. Doing all this, give the patient few days, repeat the blood investigation, the liver function, and see whether there's any improvement to this. Most of the time, the patient may be still in sepsis and we may not be correcting it well. Get a scan, see whether there's any form of collection. This patient has enterocutaneous fistula. They may have some collection in the abdomen that we may have missed, and patient may have some form of lingering sepsis. That will give stress to the liver itself, and patient may be still in an inflammatory state. By draining this collection, if the patient were to have collection, it may improve the liver function and you may not need to reduce the TPN. If all of this is not there, maybe we can reduce the amount of calorie that's given. If the patient is on about 20 or 30 kilocal per kg, you can reduce it to 15 kilocal or even 10. As we know, nutrition is needed for any form of healing, especially intercutaneous fistulas.
So I think it's all about managing your patient on TPN, and the knowledge and the practice, the clinical practice on managing patients who are on TPN is very much, still a big issue in Malaysia, especially in our surgical fraternity. Do you agree with this, Ooi?
Yeah, yes, I do. I think we are a lot of times we are too fast to blame the TPN for the any derangement in the liver function, but before even looking into the other causes, like as Dr. Mohan has mentioned, whether we have solved the cause that sepsis and the initial problem, yeah, have we solved it before even blaming on the TPN bag? And of course, there are many also basic usage of the practice of using the TPN itself. That's what Dr. Mohan says. We can reduce the rate, reduce the rate, play with the amount, and the content, yeah, of the TPN to actually to reduce the effect onto the liver. Yeah. So if you can move on to the next question. Yeah. So okay. We have two viewers asking about Saint Mark solution. Do you have any opinion on this Saint Mark solution, Dr. Mohan?
Okay, there's many rehydration solution out there. You can choose any of it, but Saint Mark solution is used in some of the centers locally as well as abroad. There is a way of making this solution even at home. You can even ask the patients to make it. Usually it has about 1 liter of fluid, sugar, as well as salt and a bicarb. I'm not sure the ratio of it, but we will add all three into a 1 liter of fluid and ask the patient to take sips of that fluid throughout the day. Yeah.
Yeah. So, Mr. Shukri, do you practice using Saint Mark solution in your center?
No. The thing is, if you were to follow the nice fluid regimen therapy, you have this resuscitation period, then the routine maintenance, and the acute patients who have, inflammation, the issue of distributions, and if you have ongoing losses, like for example, in short bowel syndrome with a very high proximal jejunostomy, then you would have an ongoing intraluminal bowel losses. So you have to know in which part of the management that you are treating the patient with this kind of fluid maintenance or distributions or replacement. So we can't be giving the patient intravenous saline, for example, throughout the hospital stay. You know, from the very beginning, the patient was discharged from the ICU till 2 to 3 months down the line in the general wards, okay? Because you have to understand the physiology and the changes in the physiology as the patient comes out from the acute inflammations to the chronic parts, and then, you know, the changes in the oncotic pressure. So the most important thing is that if the patient do not have colon or the distal small bowel or even the ileocecal valve in transit, you know, you have to initiate your total parenteral nutrition as the means for hydrations, most importantly, electrolytes replacement, vitamins and trace element replacement, then only last but not least is the nutrition. Okay, so very important from the very beginning, you identify the issues and try not to mingle too long with all these fluids, because we do not know, okay, what other secondary insults that is going on. Perhaps your primary surgery could have actually end up with secondary problems like another leak, another abscess, another collections, okay? So I think that is my opinion with regards to fluid management. There's a few questions here regarding home PN. Dr. Mohan, they're asking you if you have any experience managing patient with short bowel and discharging them with home PN.
Okay, before we discharge a patient with home TPN, we need to have a multidisciplinary approach. We need to have the pharmacist playing a critical role in managing this patient. Before doing that, the patient itself need to be educated, and the family as well. Before sending the patient back home with a bag of nutrition, their house where they place, they need to have a dedicated place to store this formula. Usually we will give it about a week so of the nutrition as roughly about 5 to 6 bags, and these bags need to be placed in a dedicated fridge. Cannot be with the household products. And the area where the patient is actually preparing this TPN need to be also a dedicated area. So all this need to be looked at before we actually ask the patient to go back home with the TPN. And these patients also need to have a home pump and will need to know how to manage the TPN aseptically. So once it is educated and patient actually understood with this important process, then we need to get our pharmacist's input and get a proper catheter for infusion of this nutrition. And it's usually a tunnel type of catheters. Usually we'll see the patient almost every week with repeats of bloods to see their electrolytes as well as their liver functions. And during this time, you will replenish patients' TPN bags for a week. Patients who are long-term on TPN, we need to also keep an eye on biliary stasis and frequent ultrasound, like about 3 to 6 months, we need to repeat our ultrasound to look for any formation of gallstones, as this patient may be predisposed to it due to biliary stasis. Any form of infection, if the patient has any form of fever or raise in total white, we will have to admit the patient and look at the line itself to prevent any line-related sepsis.
Yeah, I guess we have a fair share of managing patients with short bowel and home PN. The same goes to Queen E, right? I think Queen E has the best experience with one of their patients now remaining with, living more than, I think, 5 years on home PN, and she has just recently delivered a baby TPN, isn't it, Ooi?
Yes, yes. So yeah, this lady, had a short bowel 5 years ago, she has been on the home TPN. All the challenges that Dr. Mohan has mentioned, we encountered it and we experienced it in Queen. And last year, during the pandemic, she announced to us that she's pregnant. So it was a great shock to us, but she managed to safely deliver the baby.
Healthy, I suppose. Healthy baby.
Yeah. She had some intrauterine growth restriction. The baby had some problem with that, but she did manage to deliver the baby successfully, healthy. We had quite a bit of problem with her lines.
I guess managing patient with home PN is a totally one whole set of problems. And before you, even if you manage to pass the patient from the ICU phase to the general ward, and you are contemplating upon discharging the patient, please contact some of the centers who have experience. Okay, you can manage the patient with home PN, but of course with advice from these experienced centers, or best just to refer to the center with more experience in managing short bowel as well as home PN. There's a very interesting questions here, probably for both of you, Ooi and Mohan, as a general surgeon. Okay, before we talk about patient is salvageable, survive of all these insults. Okay, you guys as a general surgeon, you have diagnosis of quite common. We see patient came with abdominal distension, acute abdomen, you open up, massive extensive bowel thrombosis. What is your take on that when you are faced with this kind of problem? You are the surgeon operating the patient and you think this patient is not compatible with life. What is your opinion? What is your take? What is your decision?
Mohan, would you like to go first?
I think making a decision on table is not easy at this point. So we actually, usually if there's massive thrombosis and there's bowel ischemia going on, this patient will be in severe sepsis. They'll be in lactic acidosis, and probability of survival is actually very, very low. So we actually can give the patient a trial of resection and keeping the patient MBM and see whether the patient actually will survive through this rocky period. If the patient actually survives through the rocky period, we have to look towards long-term IV TPN for this patient and need to discuss regarding home TPN and the burden to the patients and the family as well.
So Mohan will resect and then discuss later, and then let the intensivist manage the patient while you counsel the family. How about you, Ooi? What are your consideration in taking up the case, opening it up, without knowing that it's going to be a massive, extensive bowel necrosis?
Well, I guess I guess if you have opened up the patient and you have seen that it's a massive ischemia or necrosis has set in, then probably there is not much hope for the patient. But having said that, the patient that we shared regarding the home PN patient that we had in Queen, she had a really in fact all her small bowels were dead when we during the first surgery. But because she's young, because she's and she just had her baby at that time during the first insult, we, like what Dr. Mohan said, we gave her a chance. Anastomosis was made for the patient, and she survived until today. So it's It's really not.
I agree to that. It is a difficult decision.
Yes.
If you were to ask me personally and professionally, I would answer, we will see if the patient is young, not much of comorbidities, we will give it a chance. We have, quite a fair share of this kind of cases, 30 centimeters, only 30 centimeters, even taking it out as a proximal jejunal is also difficult.
Yes,
You
agree.
see?
Yes.
And we have had a referral from several centers, with 50s, 60s, but they are young. So we give them a chance. But then again, you have to also think about the impact and the implication, how the patient going to survive. Are we ready with the challenges? We have one patient who are left with only 30 centimeter, and today he's an avid cyclist with home PN. Okay, so the center that is that operate on him, when they broke the story or the news to the family members definitely they fainted then, and they immediately told the patient there's no hope. But he, because he's young, he survived the ICU stormy recovery, and just because of that, we managed to salvage him from that point onwards.
Yeah.
Right.
And adding to that, I have an experience when I was training in Netherlands. So what the Netherlanders did, what the Dutch do was, we encountered that a patient with an extensive SMA thrombosis. So what they did was they got the vascular surgeon to go in during the first surgery. They opened up the SMA, stented the patient, and then we came out, and then we watched the patient for 48 hours for reperfusion, and watched the patient for, so miraculously this patient the reperfused, but it does not have much complication. Patient survived with most of the bowels still intact. So after the stenting, there was a few segments that was ischemic that we ran in after 48 hours for relook that had to be resected, but we managed to salvage most of the bowel. So yeah, this is an option that I've seen, maybe if you have the vascular surgeon at hand, maybe you can consult them and see what can be done.
I would definitely agree with that, because we personally, and as a unit, we are involved with the this chronic intestinal failure day, which is on the 1st of March every year, where we submit all the data of short bowel and home PN patient to the European Society of Clinical Metabolism and Nutrition. And one of the guidelines, or one of the approach in managing such patient, is to get your vascular colleagues to help with stenting or any kind of vascular refashioning, things like that. The only thing is that if you have, of course, definitely vascular colleagues to your expand, and the other thing is that you have to remember the issue of reperfusion injury. You might be successfully re-anastomose, reinstitute back the vascularity, but the impact of reperfusion. So you have to have a very good ICU support after such endeavor. Okay, so I think we are closing to our final minutes of this webinar. Perhaps one more last questions. The questions are now keep coming in.
Yeah, now the questions are coming. Okay, so we'll just maybe choose a short one. There's a audience that's asking about the role of enterocrisis for double-barrel jejunal stomy. What's your take on that, Dr. Mohan?
Actually, enterocrisis is it actually completes the circuit, the gut circuit, and by giving a feed in the jejunal limb, in the distal limb, it actually will improve liver function, and it will also improve in biliary stasis. So if possible, like the case that I've discussed earlier, we have actually did distal limb feeding with the enteral feed, and he actually improved.
May I add to that? It also help if you do not have the home PN program, or you have difficulty in your what do you call this, your locality, to get a patient to a center where they have this experience in managing short bowel syndrome with home PN. Because sometimes when we would like to offer home PN program, we also need to see where is the patient's locality. Too far is just too impossible. So perhaps, once the patient is stable, enteroclysis will actually help to you or the patient to wean off from the TPN and all the worriness with regards to complication related to PN. I guess that is a better solution than having the patient to be hooked up to PN in a long period of time in the ward. Ooi, I think the time is up. Perhaps you would like to conclude the webinar tonight.
Sure. Yeah, I think I'm so sorry that I think that's all the time we have for today. I think in the interest of time, we have to stop here. I would like to thank all the participants for your overwhelming support. I would also like to record special appreciation to our international friends that joined us today from Yemen, Turkey, Brunei, Indonesia, Singapore, and India. Thank you very much for supporting us. I would like to apologize to you if you do not find answers to your question today, but worry not, our team will go through all the questions posted today and answer your queries via your email. With that, I would like to thank Dr. Mohan, Mr. Shukri, and our sponsor, Medtronic, for making today's session possible. I wish you all a great weekend ahead. We hope to see you again next week, same time, same day for the 8th series. But we have a new time, which is 8:30. Yeah. So stay safe and good night.
Bye. Have a good weekend.
Bye.